We are at the end of the day. We're in the plenary session now, titled African Responses to COVID-19. It's part of our lovely Sources Conference. So we're going to go until about 5 p.m. here. My name is Kristen McLean. I should introduce myself. I'm an assistant professor at the College of Charleston in the International Studies program. And we have with us 4 presenters on this panel. And what I will do is I've asked each of them to try to keep their talk to about 15 minutes or so. So we have about 30 minutes for Q&A at the end. So if you will, I think what seems to be working well, at least virtually so far, is that we allow our 4 presenters to go and then hold questions off until the end. So we'll hopefully have a good 20-30 minute chunk for Q&A. You're welcome to type questions into the chat feature as we go along, as you have them, if you want to, or you can jot them down, obviously. But if you want me to sort of keep in order, I'll just go from the top to the bottom. So with that, our first speaker, and I'll just introduce each of you individual, but our first presenter is Danielle Boaz from UNC Charlotte, and she is presenting a talk entitled Religious Freedom versus Public Health, East African Responses to Religious Gatherings and Ceremonies During the COVID-19 Pandemic.
Okay, and I just go ahead and go, right? I'm going to introduce everyone.
Sorry, I'm Andy.
Right, I just go ahead and go.
Yes, sorry about that. I'm on mute.
All right, I just wanted to confirm. Okay, good afternoon, everybody. So as Kristen said, my name is Danielle Boaz. For those of you who don't know me, which looks like most of the people on the chat, I am actually a legal studies scholar. I work on race and the law, and I work on law and religion. And most of my work focuses on something I call religious racism, which is kind of like the intersection of religious discrimination and racism. So I work a lot on like African diaspora religions and law. But I'm also very interested in religious freedom more generally. And since the start of the pandemic, one of the things that I've been following very closely is the restrictions that different governments have placed on religious gatherings and how they've responded to evidence that religious leaders or religious services have led to major outbreaks of COVID-19. I recently, I think about 6 months ago, actually, I published an article in the Journal of Law, Religion, and State titled From Essential Services to Culpable Homicide, State Responses to Religious Organizations and the Spread of the Novel Coronavirus in 2020. And I'll actually later drop a link to that in the chat because it is free to access even for people who don't have a subscription through their university. And this article, it talks about how governments in South Korea and India actually arrested religious leaders for culpable homicide after gatherings that they held before the actual start of the initial lockdowns were traced to thousands of COVID infections. And then it contrasts that against Brazil and the United States, where, as I'm sure most, if not all of you know, we've had these enormous Protestant churches that have been holding services with thousands of people, even after the official start of a lockdown. And these churches have typically very strongly advocated for their right to continue to hold services, and they've faced very little consequences for even documented cases where people have become infected during religious services or have even died from religious services. So as I was doing the research for that article and trying to identify exactly where I was going to focus on in this sort of broad survey of state responses to religious organizations during the pandemic, I started to become fascinated by some of the reports that I was seeing from East Africa. And this is what I'm going to share with you today. Although as I was practicing the talk, I only really got through sufficiently discussing one example in detail and then kind of jumping forward into another. So we'll see how far I actually get and how slow I kind of read through things today. But basically what I'm starting is a project that's looking at Kenya, Uganda, and Tanzania and the responses to religious organizations in these 3 countries. But I'm going to start with Kenya, and we'll see if how deeply I can get into the other ones. All right, so In mid-March of 2020, Rome-based Catholic priest Richard Odor flew home to Kenya for a family member's burial. For approximately 10 days, from March 11 to March 20, Odor traveled throughout Kenya on public buses and planes and celebrated several masses. He also gave the Eucharist to attendees at his relative's funeral. Then, on or around March 20, Odor became ill and was hospitalized. He tested positive for COVID-19. And we may recall that the World Health Organization had declared COVID-19 a pandemic on March 11, 2020. So this was the first day of Odor's travels. You may also recall that at this time, Italy, where Odor was coming from, was one of the centers of the coronavirus outbreak. So Odor seems to have been one of the first documented cases of COVID-19 in Kenya. It seems that he may have been around case number 7 or 8. So it was, I say all this to say it was very big news when he was hospitalized and tested positive for COVID-19. About 2 days after he was first hospitalized, the Directorate of Criminal Investigations issued a statement indicating that any person found to have knowingly spread the coronavirus would be arrested for contravening the Public Health Act and ordered to pay a fine of 30,000 shillings and serve up to a 3-year prison term. That same day, the president addressed the nation and threatened, quote unquote, severe action against people who didn't follow the health ministry's guidelines. So while Odor is in the hospital, Kenyan authorities start investigating his travels throughout the country. Allegedly, their investigation revealed that he had been in close contact with at least 247 people during his travels. And then there are these early reports that are very kind of confusing and sort of all over the place. But a number of them suggested that around 60 of the people who he had come into contact with tested positive for the coronavirus, including several priests, nuns, and members of Odor's immediate family, as well as neighbors of the person whose funeral he presided over. It's important to note that if accurate, this would have meant that he had been a primary source of the spread of the coronavirus in Kenya. As of mid-April, a month after his hospitalization, the start of his hospitalization, Kenya only had 234 diagnosed cases of COVID-19. So at least 25% of Kenya's cases would have been directly traced back to him. And I specify this because there seems to be a strong correlation between situations where a country had a large percentage of early outbreaks being connected to a particular religious leader or religious meeting, and a state's strong crackdown on either specifically that or those religious communities during the lockdown or religious communities more generally. Because of Odor's failure to self-quarantine following his arrival from Italy, Kenyan officials arrested him for negligently spreading an infectious disease in violation of the Section 186 of the Penal Code as soon as he was released from the hospital in mid-April. And this section makes it a misdemeanor for any person who unlawfully or negligently behaves in a way that he knows or has reason to believe is likely to spread the infection of any disease that's dangerous to life. It's punishable by a term of imprisonment for up to 2 years or with a fine or both. And this is slightly different than the term that this is slightly different than what the punishment would have been under the Public Health Act that that had been previously threatened, that the Directorate of Criminal Investigation said that people would be sentenced with. So Odor spends 4 days in police custody following his arrest, including the entire Easter weekend. His arrest was based on the fact that the Kenyan government had directed all those returning from foreign countries, as well as incoming visitors, to self-quarantine for 14 days to check whether or not they may have contracted the novel coronavirus while they were traveling. So he was accused of violating the penal code because he didn't follow this directive. Odor was the second person in Kenya to have been arrested for negligently spreading COVID-19. The first was a deputy general who had traveled to Germany and refused to quarantine or failed to quarantine when he returned to the country on March 6. Oduor said that he did not know about the government's order, and he also contested his positive result when in his coronavirus test. He furthermore said that he was hospitalized for something unrelated to COVID-19. So when he first checked in, apparently he reported that he was suffering from nausea and shortness of breath. But later, after he was discharged and after he was arrested, he said that his symptoms were not related to these things, and that he didn't believe his supposed positive test for the coronavirus. Almost exactly 6 months later, in October of 2020, the prosecution withdrew its charges against Oduor after having to continue the case at least 9 times because the prosecution did not have sufficient witnesses or medical records to proceed with the case. And this seems to have been connected to both proving that Oduor himself had been positive for the coronavirus, as well as proving that he had infected these dozens of people, as the initial report suggested. And when they withdrew the charges against him, the state council told the court that they thought that the public interest in the matter had already been served in deterring negligent behavior in society that's likely to risk one's life or the life of others. And this statement was really, really interesting as a kind of justification for withdrawing the case, because it was basically the state council saying, look, we've kept this case going for 6 months. We've made an example out of this guy, and we're going to drop the charges. But it seems like they were more concerned with, in the early period of the outbreak, of making sure that they deterred people from coming into the country and failing to quarantine. And then after the kind of initial period of the pandemic had passed, that they were less concerned with prosecuting him and less concerned with determining whether or not he had actually spread COVID-19 to other people. Interestingly, at precisely the same time that the government dropped the charges against Oduor, they pursued the case against the deputy governor, Gideon Saburi. Both cases had suffered from similar delays and challenges about the accuracy of testing and things of this nature. But perhaps what is most interesting to me about this case is that Saburi had traveled a week earlier than Oduor and was in Germany rather than Italy. So of course, Italy was, as I said earlier, one of the kind of epicenters of the outbreak at the time, much more well-known area of outbreak than Germany. And Saburi had returned to Kenya prior to the declaration of the WHO's declaration that this is a global pandemic. And also, it seems prior to Kenya's first known case of COVID-19. So I think all of these things are important to thinking about why these cases are handled differently. And in the long term, one of the things that I want to do with this, because I'm still in the very early stages of kind of processing these cases and thinking about what they all mean, in the long term, one of the things that I want to do is try to overlay the timeline of government responses to religious organizations more generally with Oduor's case. So one of the things that I've noticed is that within a couple of days of his hospitalization, the government shuts down all churches, mosques, and other places of worship. They also ban international flights and limit the number of people who can attend funerals. So all these kind of elements that made his case this, kind of dangerous, this dangerous intersection that could infect a bunch of people, these things are suddenly banned. And it seems likely that authorities already had this case in mind as a reason to implement all these restrictions, because even though Oduor had not yet been arrested, news outlets in Kenya were already widely reporting his travel and expressing concern about his positive test result and the number of people who he'd come into contact with. So from here, I really wanted to go on and to get into a discussion about what was happening in Uganda. I'm noticing, because I did a little timer of my own, that I'm down to just a couple of minutes. And so I'm going to just point out a couple of things very briefly in the interest of keeping us close to that 15-minute mark. So in Uganda, by mid-March, even before Uganda had registered a single case of COVID-19, the president had banned large public gatherings, including religious services. And following this, numerous pastors and worshipers were charged with violating these public health regulations. I'm not sure, I'm trying to get a sense of how many people in total may have been arrested since the start of the pandemic, but it actually seems likely that it's somewhere in the hundreds. And so I just want to kind of point out a couple of things that are really interesting about these prosecutions that I've been looking at. So one of them is that in the early days of the pandemic, it seems like there were several church services that were broken up in situations where you had maybe kind of rural churches that people were traveling to from long distances. And because of some different travel restrictions or just in general issues with transportation and mobility, that people were kind of stuck at the church and unable to make their way back home. And so in some of these cases, the pastor of the church continued to be prosecuted for violating bans on gatherings, but the churchgoers were let go with a warning. And so I find that interesting because this is something that's kind of common throughout the world. A lot of places were having these religious gatherings kind of on the cusp of government shutdowns, of government restrictions on mobility and gathering. And then a lot of them have been surprisingly strictly prosecuted for violating those orders, even though they were kind of in this tough place where maybe worshipers could or couldn't leave. And then the other thing that I'm noting is that, especially after some time passes around August or September, a number of religious services, typically Protestant Christian services, are being interrupted, and everyone in the space is being arrested. And so this is particularly unusual in a global sense, that most of the time only religious leaders are the ones who are arrested for violating these public health regulations. And so it's something really interesting that everybody there is being held accountable for attending these religious services if the numbers or type of gathering violates the rules. And the other thing that stands out about them is that rather than places like the US, for example, or Brazil, where pastors are very outspoken about their right to continue to worship and their intent to defy restrictions, in Uganda, people were being reported by neighbors. They were giving tips to the police, and then the police were coming in and raiding them. And so I want to think about what that different intent in breaking these regulations and ultimately being prosecuted for them leads to. So I see that I'm probably over time now, so I'm just going to wrap up there by saying that I'm just continuing to think about what all of these different cases and examples mean and how the regulations on religious organizations in East Africa compare to that in other parts of the world, and why and what it means. Thank you.
Great, thank you so much, Danielle. Again, just for those who came in a little bit later, I've asked the audience members to please hold questions until the end, and then we'll take a number at that point, but you're welcome to go ahead and type questions into the chat feature. So next we have Chris Paul from North Carolina Central University, who's going to be presenting a talk entitled Capacity and Complications, Understanding How the Ebola Crisis Affected the Function of Civil Service in Liberia. I'll turn it over to you.
Thanks so much, Kristen. And so I'm going to share slides. Hopefully that will cooperate. Can you see those okay? Yeah, that looks fine, Kristen. Okay, great. Thank you. Thanks again for hosting this, and to the organizers and to all of you for joining. Again, I'm Chris Paul. I'm an assistant professor of public administration at North Carolina Central University. And this is my first time attending a CERSAS conference, but I had been in touch with Christopher Day and really appreciate the outreach. My background is in global health policy, and I have had the good fortune to work with colleagues in many places, including Liberia. And so I have a lot of interest in the scholarship of this group and today. And so indeed, this project arose out of a partnership that my department has with the Liberian Civil Service Agency. The Civil Service Agency staffs and provides the human resources infrastructure for all of the national government systems, from telecommunications to water to the Ministry of Health. And in our discussions with our colleagues, we placed students there for externships. I became curious about how the Ebola epidemic had affected the function of government and civil society more generally. Appropriately during that epidemic, the focus was on disease control. Ebola is a terrifying disease and caught the attention of everyone. But in fact, the sustained direct effect from the disease and severe disruption have had far-reaching effects on the rest of society. And much of the analysis of the 2014 epidemic is focused on the international Ebola response, which is at the end of the day, or the end of the epidemic, the international and foreign actors were not, in fact, the essential force in responding to the crisis, and have been appropriately criticized for being flat-footed and impotent in that case, and which is now driving changes in the response to our pandemic today. And rather, it was Liberians, both in roles official and unofficial, who drove the response to the Ebola epidemic. The combination of the delay of the World Health Organization and other international organizations to respond, combined with the ironic focus of international actors on the weak state and limited capacity of the Liberian government, and particularly its health system, detracts from the important reality of the role that Liberians throughout society played in stopping the epidemic. Indeed, much of the early negative media attention during the Ebola epidemic and even some scholarship was given to the superstitions of Liberians and others in West Africa, the use of traditional medicine and cultural practices around burial, which really obscured, in fact, the capacity and agency of the response by Liberian professionals and the coping and adaptation of individuals. And then as well, the substantial failure of development efforts and so-called capacity building over a much longer history. Now, Liberia faces new epidemics, both in COVID-19 and the re-emerging threat of Ebola in the region. As our chair of this panel, Kristen McLean, this morning, and another panelist, Amson Hagen, discussed, the question of agency in the face of crisis versus waiting for action is clear. Agency is the capacity for action, and as other speakers have shown today, no one chooses to stand idly by in the face of a threat or a crisis, waiting instruction from an outside force about what's important for their survival and well-being. And this was reemphasized this afternoon by Dr. Yvette Asunga when she reminded us how broadly African nations and peoples have responded independently and effectively in the COVID pandemic. So I think my paper, in many ways, is trying to investigate the same thing. What are the pathways of action held by people, and particularly here, the public servants in the face of crisis? From the perspective of the state, epidemics present a crisis of capacity. Disasters and epidemics test this capacity at all levels, from the individual household to the highest levels of leadership and government. Between the policymaker and individual households, many public servants, including health workers, educators, other government functionaries who attempt to deliver services in spite of threats, personal danger, lack of pay and support, still show up. Epidemics may strain the capacity, but as in the case of Liberia, and the examples given by other speakers today, there's great resilience and local response. Epidemics are foremost public health events, but we must not neglect the reality and the ways these effects linger in both the experiences of individuals and in the function of the state. Ebola infected many health workers, directly limiting treatment and care of the ill. Further, however, service provision by the government was more broadly disrupted as offices and schools closed and civil servants themselves were threatened with the disease. With scholarly and policy attention on disease and control, there has been limited consideration of the secondary effects of the crisis of priority shifting and personnel changes, the risks and adaptation of agencies. So this study initially focuses its investigation on the capacity of the Liberian government broadly and then specifically on the civil service following the Ebola crisis of 2014, 2015, and then turns to the COVID pandemic today. And although the medical and public health initiatives ostensibly fall into the domains of those specific agencies, the Ministry of Health, the wide-reaching impact of Ebola, both directly on the personnel in the agency operations and indirectly on the policy priorities and fiscal flows among agencies, foreign aid disbursement, programming, and policy, all shifted the function and priority of services in government agencies. And these policy shifts may have unintended consequences, both positive and negative, on government function and in services in anticipation of current and future epidemics and risks. Ebola arrived in eastern Liberia from neighboring Guinea in early 2014. The national newspapers downplayed any threat. And as I tell the story of the Ebola epidemic, I think we'll hear echoes today of what we see in the US and elsewhere. But by 2014, in July, there were 288 cases, and the Liberian government closed schools and limited public gatherings, including sporting events, affecting the lives and livelihoods of nearly every household. From there, the epidemic grew to claim at least 4,800 lives and affect tens of thousands more. The epidemic disrupted lives and altered livelihoods by limiting government services, including severe restrictions to trade and the closure of schools. It also particularly undermined other healthcare by diverting resources, shuttering facilities, and decimating healthcare workers. Healthcare workers in Liberia, unprepared for the epidemic, faced incidents of infection on orders of magnitude greater than the general population. There, at the time of the epidemic, there were about 100,000 patients per physician in Liberia, and perhaps 15% of all Liberian health workers died in the epidemic. And then further, many of the doctors who died were medical educators in their nations. Their death was a major loss. And so not only was there this direct risk to healthcare workers, but this exacerbation of the function of the state disparities reached far beyond the health system. The provision of services by the government was broadly disrupted as the civil servants themselves were threatened. Scholarly literature on the epidemic navigates the important tensions when understanding Liberia's implicit capacity to respond to the epidemic. As much discussion focuses on the pre-existing lack of capacity in Liberia and other countries, arising in part from both the recent and long history of civil strife, failed development, and ethnic tensions. That's FALA 2015. But Paul Farmer and others have called Western international policymakers and scholars as well to task for the culpability we share in these historical realities that drive present-day capacity to respond to crisis. Further literature explores the particularly challenging nature of epidemics. And this, again, sounds familiar when we put it in the context of the COVID-19 pandemic. The rapidly evolving nature of the crisis, the shocks that are continuous as opposed to discrete with most other disasters, the asymmetry of information and what's needed. For example, in Liberia, a lot of initial communications were about Ebola is real, and as opposed to the need for actual tools or support for improvising personal protective equipment. And then the severe effect of this epidemic on all who responded, both in the direct mortal risks as well as the emotional trauma. And so much of the literature on the Ebola epidemic focuses on the frontline public health response, but I think there's an untold story about how the rest of government functions, responds, and adapts to a crisis such as epidemics. And so my goal is to frame that institutional response outside the frontline work in light of the relatively more extensively studied public actions. So, capacity is the ability to act, or agency, as we've heard it described elsewhere today. And we hear a lot in public health about capacity and capacity building, the structures and resources and ability of systems to respond to improve health. And then further, we can think of this capacity as the ability for government function through the development and implementation of policies. And elements of capacity include organizational strength, human resources, institutional systems, but a crisis like an epidemic tests each of these elements. Often the scholarship assumes that and focuses on the state level capacity as being weaker and less able to adapt and implement new policies. And much foreign assistance aid, of course, has been focused on so-called capacity building. But I think institutional capacity should be thought of at multiple levels of both formal and informal institutions. Though we often abstract away to the state level, the temporal and programmatic heterogeneity of the responses in the Ebola crisis underscore the need for us to disaggregate from just the state's capacity. Especially as we can have our own new pandemic to think of, to respond to a pandemic, it's not a surprise that we need a multi-level response and ultimately funding and action at all levels. And in Liberia, when Ebola arrived, it was the local leaders, including political, religious, and community health workers that were the ones who were there. This contrast, I think, to the way that the international community responded, focusing on that lack of leadership locally, despite that culpability at the highest and highest resource levels throughout the world. And so the exposure of the Ebola epidemic exposed that inadequate capacity at all levels, not just at a local level. So in my paper, I focus on the civil service agency of Liberia, which represents all of the staffing, professional staffing of the government agencies in the country, and has been particularly focused on using on reestablishing a meritocracy of skilled civil servants, including those from those expatriates who have returned. And so the capacity, the multiple forms of capacity that this agency provides are critical for response to epidemics. But in my interviews in 2017 and 2019 with members of the CSA in trying to understand the impact of Ebola, it became clear that this capacity is very idiosyncratic and dependent upon individuals' own resources. And one of the ways that this stood out in the way that civil servants responded and adapted in the Ebola epidemic was their own provision of logistical resources, namely their own computer systems, their own private emails, their own private cars, and their own private phones and communication systems. And so this not only suggests a deep commitment by the officials within the civil service, but also that lack of structural capacity, but substantial strength of individual capacity in responding to the case. And so before there was strong international support to respond to the Ebola outbreak, the Liberian civil servants established strong contact tracing systems and were able to work in concert with foreign colleagues to develop epidemic tracing software. So let me just see, and I'm approaching the end of my time. So this conference today and working on this presentation has been really useful in trying to think about where the lessons of COVID or where the lessons of Ebola fit into what we can understand in COVID and in other settings. And Liberia, like a speaker today described for in other African nations, has been able to be very successful in controlling COVID. In fact, very rapidly, they launched a contact tracing and border controls, and were able to implement a lot of the lessons from Liberia and as well as public health. But conversely, there's been really extreme economic disruption through the lockdowns. And so in that sense, COVID's had a really mixed impact on society. And of course, these shutdowns and the general economic contractions have harmed the most vulnerable. And so I think this again responds to this need to understand local capacity and local response. I did want to point out that the former CDC head for Liberia, who's now based in the United States, actually described his shock being here in the United States as last year, as the US was unable to implement many of the contact tracing procedures that Liberia had worked with them to develop in 2014 and 2015. And so, I think this is, this is all to say that there's a really important way that we need to think of capacity, and not just at the state level, and not just from an international perspective, but to really think about what is needed to support individuals, decision makers, individual civil servants as they develop the capacity they know is needed in their domains and in their nations and communities. And I really like this title to Paul Farmer's op-ed in 2015, that the secret to curing West Africa from Ebola is no secret at all, that it's not some magical lack of capacity that needs to be added by the West, but to instead recognize and support and resource the individual public servants in Liberia. So thank you very much, and thanks of course to our partners in the Liberian CSA. I appreciate you hosting me today, and I certainly look forward to any questions you have.
Great, thank you so much, Chris. Excellent. So I'm just gonna, there we go, perfect. Thank you for doing that. Okay, so we're just gonna move right on to our next presenter. And again, I see one of you has already posted a question in the chat function, so please feel free to do that. So next we have Seth Palmer from Christopher Newport University, and he's going to be talking about Pan-Africanism and Malagasy nationalism in the marketing of COVID organics. So Seth, you are up.
Hi, everyone. Hopefully you can all hear me. Cool. All right. So I'm just going to launch right into this. I'm going to skip around because it's a bit longer than it should be. On April 20th of 2020, Malagasy President Ange Rajoelina officially presented to the world a new miracle remedy to help prevent and cure the novel coronavirus that was rapidly spreading across the globe. Dubbed COVID Organics, or CVO for short, the treatment is an herbal infusion produced by the Malagasy Institute of Applied Research, IMRA, an independent research center that nevertheless has entered several contracts with the Malagasy government, which allow IMRA to sell herbal remedies in local public healthcare facilities. Rajoelina promised that the remedy, principally composed of sweet wormwood, a Chinese plant first imported to Madagascar in 1975, by Dr. Ratsima Mank, whose image is actually pictured here behind the president on that white sheet, and Raventsar, a plant endemic to the Red Island and highly regarded for its curative properties, can mitigate and even prevent COVID-19, the illness which follows infection with the SARS-CoV-2 virus. Within several days, COVID Organics was distributed in large barrels throughout Antananarivo, the capital of Madagascar, and its surrounding communities. Even though the Malagasy Academy of Medicine warned against the use of COVID Organics, since it had not yet undergone clinical trials, Rajoelina pushed the product, and eager citizens nevertheless brought empty plastic bottles, which were then filled with the herbal infusion. With the exception of the coastal city of Tamatave, Antananarivo was and remains the epicenter of the outbreak in Madagascar, and special priority was given to school children and neighborhoods with documented spread when determining where CVO should be allocated. The story was immediately picked up by international news outlets from BBC to Le Monde. Just days after Rajuel's announcement, coverage of the story in Untitled noted that, quote, "It remains to be seen if the effectiveness of this remedy will be confirmed in the coming weeks." Nearly a year later, Madagascar has since faced over 20,000 active cases and 300 deaths from COVID-19, and supporters of CVO are now somewhat less jubilant than they were when the product was first distributed to the populace by armed forces throughout the city. However, as Malagasy soldiers ran free CVO dispensary centers beginning in late April of 2020, my Facebook newsfeed was filled with the posts of Malagasy friends who were overwhelmingly supportive of Rajuel's announcement. Some mocked negative French news coverage of the cure so as to illustrate the racist former colonizers' skeptical gaze upon COVID organics. Much of this coverage was critical, as in the New York Post's sensationalist description of a, quote, supposedly magical concoction, quote, and harsh pushback from French journalists Marc Perelman and Christophe Boisbouvier in Rajuel's now often referenced May 11th interview on France 24. To Boisbouvier's assertion that Rajuel had, quote, created the illusion of a miracle remedy, Rajuel replied, "One should not underestimate African scientists and Malagasy scientists. The problem," Rajuel continued, "is that it comes from Africa." When journalist Perelman noted that accusations of charlatanism were not simply being directed at Madagascar, but also at French pharmaceutical companies that pushed the use of sweet wormwood, Rajuel once again defended CVO. The result is there are no deaths. Malagasy senators later backed Rajuel's much viewed retort to the French journalists when they said, these being the Malagasy senators, "The problem is that CVO is from a poor country. If this wasn't the case, it would have turned out differently." There's a famous case of Tons Main, a very famous pop singer in Madagascar who was hospitalized for 43 days from COVID and claimed to have been cured by CVO that I'm just going to skip over here. Based on my online engagement with longtime interlocutors from Madagascar, my preliminary sense is that most were excited to back Rajuel's message of Malagasy pride. Before the island could count any casualties caused by the novel coronavirus, a Malagasy national who completed graduate studies in the United States remarked on the social media site, quote, "We drink it, Africa accepts it, it helps us with COVID-19, and we don't yet have any deaths here." By employing the exclusive form of the third person pronoun Izahai in Malagasy, the writer directed their nationalist message to an explicitly non-Malagasy audience. Other viral Facebook posts include that by Mr. Rachiamuri Vun, who argued that COVID organics was a solution proposed, quote, on a Malagasy television channel in Malagasy and for the Malagasy people. This is not your problem. Criticism of international actors, but especially European ones who challenge the legitimacy of COVID organics, has been central to Rajuel's CVO marketing campaign and is one that has been reproduced in these buzzworthy Facebook posts. It is perhaps noteworthy to highlight that foreign criticism of CVO came on the coattails of the statement made by the two French doctors, as I'm sure all of you here are aware of, right, that these COVID vaccines should first be tried out on Africans. Foreign critics are thus left in the difficult position of having to carefully frame their hesitations in the hegemonic language of scientific positivism, lest they be charged with the assertion that, as Rajuel himself claimed, quote, "The problem with CVO is that it comes from Africa." Unflattering news coverage of the Malagasy miracle cure in the Western press derided the unscientific, untested remedy proposed by the sitting national leader. Yet these criticisms were all too often silent on former American President Donald Trump's efforts to push household bleach, UV rays, and hydrochloroquine as appropriate remedies for C19. That relatively little news coverage on COVID organics applied such a comparative perspective is perhaps revealing of the fact that for even well-educated, perhaps less ethnocentric Western media consumers, the CVO tale reinforces the always present assumption that African traditional medicine is incompatible with scientific standards. So while Madagascar is often framed as a nation in need of healing by outside commentators and Malagasy citizens alike, The CVO solution reframes the conversation. Now, in the era of coronavirus, the solution is homegrown, and furthermore, it is a Malagasy emulsion that will aid foreign nations used to acting as humanitarians themselves. In this role reversal, CVO is a distinctly indigenous response to this clearly global problem. Rajoel's ambitions for CVO extended beyond preventing viral spread across the island nation as he pitched the herbal remedy to foreign governments, especially African governments, and I'll talk about that briefly later. So I also have a section that I'm going to skip over on the history of what we call tambaf or mangidi in Malagasy, these kind of herbal infusions. And one thing that's interesting to note is that they're popularly, you find them usually being sold by young or middle-aged men at bus stops or marketplace, at the marketplace. So in this way, by touting CVO, Rajoel's actions mirror those men who have long sold these herbal infusions on the streets of Antananarivo, similarly lauding the emulsion as both the preventative measure and a single-handed cure for a variety of ills. Curiously, the botanical protagonist in the CVO story is not an endemic Malagasy plant, but a Chinese import. In various interviews and appearances, Rajoel has noted that CVO is composed of, quote, medicinal plants that are purely Malagasy. Nevertheless, Artemisia, which composes 62% of CVO, was again first imported from China in 1975 by Dr. Ratsima. The appeal to nationalist sentiment, to something that is, quote, purely Malagasy, is critical in understanding the relationship between CVO and Malagasy identity, which has long situated itself vis-a-vis that which is exterior to the island and which is encompassed in a single word in Malagasy, that of andaf. So initial attempts to grow Artemisia on Malagasy soil were part of the vision of IMHA, this institute. Since the mid-2000s, the Central Highlands of Madagascar have proved an important source for the global production of sweet wormwood, a plant that has long been understood to have medicinal properties. The Antananarivo-based company that oversees the Malagasy production of Artemisia supplies several important pharmaceutical laboratories with the plant. Meanwhile, the international scientific community pushes for more research to assess whether the plant is truly effective in both combating and preventing malaria, a disease which, as far as I know, has no connection or similarities to COVID-19, although I am by no means any expert. So I'd love to hear thoughts from folks who would know more about that. While it is beyond the scope of this paper, botanical imagery and metaphor has long played a role, as you can imagine, in colonial, nationalist, and international political struggles on Madagascar. And in the neoliberal era of Malagasy governance, endemic plants have been crafted as a source of both Malagasy pride and opportunity, whether this is in the form of conservation funding or international pharmaceutical markets. By the period of the Second Republic from the 70s to early 90s, the creation of IMHA was understood in popular Malagasy memory as, quote, according to historian Didier Galbert, as, quote, the founding act of a national and medicinal science based on an insular form of medicine. While framed in the contemporary moment as a nationalist project born at the dusk of French colonial rule, in reality, the institution and its founder, who I've mentioned several times now, Dr. Ratsima, was a scientist trained in the metropole during the colonial period, and himself was also an anti-colonial crusader. These are much more complicated stories than easy post-colonial binaries would suggest. So rather than trying to resort to ideas of the cure as either simply kind of colonial or decolonizing or post-colonial, I think it's important to consider the complex entanglements through which anti-colonial Malagasy voices themselves often have reappropriated colonial ideologies. So thus describing CVO as an example of the, quote, misuse and co-optation of Pan-African rhetoric, it's useful insofar as it allows us to consider the economic interests that lie behind this, quote unquote, African cure pushed by a businessman politician. It somewhat conveniently ignores, however, the contested vision of what Pan-Africanism is. And in the case of Madagascar, this is particularly fraught given the island's peripheral relationship to a politically invaluable yet essentialized sense of Black identity. And I can't go through this. There's a lot to unpack, so I'm going to try to just skip over some of that. Rajoel's Pan-African rhetoric, however, is perhaps surprising given the role that Pan-African organizations have played in challenging his ascension to the presidency in 2009, which was labeled a coup d'etat by much of the international community. The African Union, after all, suspended the Malagasy government during that time. At times, it is surprising to see Rajoelina use the marketing of CVO to rally behind an African identity. At times, he explicitly separates or differentiates African scientists from Malagasy ones. Rajoelina's call to his, quote, African brothers and his cry, quote, long live Africa and its natural riches, was reproduced in statements by other politicians, including Malagasy senators. And as you can see here, this is representatives of the Tanzanian government taking CVO as gifts back to Tanzania from Madagascar. And this has since been brought to Chad and many other African nations. And even the Haitian president has lauded Rajoelina for the promotion of CVO. In the era of COVID organics, there is a potential economic advantage, I argue, in finding a new market for CVO in Africa. 60% of IMRA's profits are gained through exports, and in this sense, a Pan-African pride can also be lucrative. It provides an opportunity to broaden IMRA's consumer base and to uncover future South-South markets. A 2010 study of IMRA by an international group of public health researchers noted that, quote, IMRA also intends to expand the market to other African nations in the next few years and has expressed interest in working with other African national health authorities to create commercial links. Based on conversations with Malagasy friends and interlocutors, as well as the existing literature, most Malagasy nationals are very clear to differentiate themselves from Africans in continental Africa. Again, I'm going to skip over some of that here. Ratsimanga himself, who's again pictured here, and his ghost was literally hovering over the unveiling of CVO, has a lot to say about this. The perpetuation of these racial ideologies is undoubtedly a consequence of colonial rule, but even in the early post-independence period, Malagasy scientists and politicians continually reproduced the assertion that Malagasy are primarily not African. The founder of IMRA, here again, Ratsimamang, described Malagasy royalty as, in his physical anthropological research, as essentially, quote, Indonesian. He further argued that the Malagasy population could be divided into 4 subpopulations: 37% Indonesian Mongoloid, 52% Negro-Oceanic, 9% Europoid, and only 2% African. The first president of Madagascar, Tirana, differentiated Madagascar from continental Africans by referring to the nation as Afro-Asian. My scholarly interest here is not to judge or condemn these disavowals of African origins, and I can't really unpack all this here, nor do I assume to know what Rajoelina himself thinks about Malagasy identity as it relates to Africa, but I rather want to paint a much more complex portrait of Pan-African solidarity and Malagasy identifications with Africa and African than Rajoelina has most recently asserted in these CVO marketing moves. Okay, now the conclusion, very quickly. Not all African interlocutors, however, have been won over by the romanticism of Pan-Africanist rhetoric in the marketing of CVO, and you've had several Congolese researchers speak out against CVO, and the African Union has pulled together with the African CDC a kind of a way to move forward with African herbal treatments in order to test them, to provide some sort of sense of how to move forward with kind of clinical trials here. In the end, the scientific effectiveness of COVID organics in both preventing and treating the novel coronavirus may be of less domestic political consequence than the marketing of the product itself. Rajoelina has, for the time being, effectively bolstered Malagasy nationalism under the Pan-Africanist sentiment of CVO, although it's certainly something that I hope to study later when I'm able to go back to Madagascar in person. We are a sovereign nation, Rajoelina retorted to the French journalist during his interview on France 24, underlining the fact that for Malagasy political leadership, COVID organics is a question of national and botanical sovereignty. And I've tried to suggest in this paper that segments of the Malagasy population see CVO as a key site in which Bajuelen has referred to as this war against the novel coronavirus. Thank you.
Great, thank you so much, Seth. Okay, so we are moving along to our fourth and final presenter for the panel today, and that is Moses Kisa of North Carolina State University, who is going to be speaking to us about countering COVID, militarism, securitization, and regime politics in Uganda. Moses, I think you're muted.
Okay.
There he is. Hi there.
Oh, thank you, Christine. Yeah, I cut down the title of the talk a little bit, but in any case, thanks a lot to the conference organizers and all of you who have made time on Saturday evening to stick around. So I would appreciate feedback on this, because I'm trying to write an article going forward, and these are very rough initial ideas that I'm going to speak to today. And so, I very much would like some concrete and practical advice on sort of the framing and the issues I can address in this paper. So this also comes as part of my ongoing work on studying African civil military relations, work that I've been doing with some colleagues, including Chris Day, who I think is not here. So as it's been spoken about, for the whole world, but especially for the African continent, the challenge of confronting COVID has been and remains a big issue. And in the case of Africa, the concern has been about the institutional, but also the resource constraints and limitations of African states. Part of what Chris Paul was speaking about earlier as regards to capabilities and the resource abilities of African governments. And again, not to belabor the point, we had earlier predictions about a coming slaughter, doom days ahead for Africa, and the fact that the continent was going to be the worst affected. Obviously, as matters stand now, we don't know what's going to happen in the future, of course, but at this point, those predictions haven't been accurate, and the continent has not been as ravaged as it had been initially thought to be. And of course, in many of those predictions, a number of the things that were overlooked, some of which earlier speakers have underlined, include things like experience with managing epidemics in the recent years, particularly the Ebola virus, but also the Marburg flu, which many countries on the continent have recently dealt with. And so in West Africa, but also in East and Central Africa, and Uganda is one country that has had some strong and hopefully useful experience managing epidemics, which may have come in handy by way of some of the existing health infrastructure that still remained in place. But of course, there are also factors like young population, as well as social resilience. I think something that one presenter spoke about earlier this morning. Many African communities have dealt with enormous disease burdens for a long time, and this pandemic was not going to be something that would be extraordinary in terms of the communities that have dealt with real tough health conditions for a long time, and so I think in some ways there is something to say here about the resilience of many African communities when it comes to managing the kind of disease challenges that this pandemic brought. So the case of Uganda, which is the focus of this paper, there was a real swift, response that the Ugandan government took very early on. I think the World Health Organization announced the pandemic, as so. Early March, I think within about 10 days, on March 22nd, the Ugandan government moved to shut down the only international airport at Entebbe. And then a week later, by the end of March, a national lockdown had been announced by the president. Now, from the onset, the Ugandan president basically defined the problem as a security matter. Of course, this was not unique to Uganda. I think many governments around the world coached the language of tackling the pandemic as a matter of national security. I think presidents, including the U.S. president here, was talking about being a wartime president. So what we see is the securitization of a public health problem, which basically means that, the government is approaching a public health emergency as a security operation that requires, using all the, state's coercive resources that can be marshaled. In this case, especially when you have a government like the one in Uganda. And so, defining a pandemic as a security matter meant that, the whole notion of the standard operating procedures, SOPs, was in sync with the language of military operation, right? And militarization. And so this meant that the military was placed right at the center of all the COVID response activities that the Ugandan government had to undertake. As one perceptive analyst pointed out, and here is, a lengthy quote saying that if considered that SOPs is a lexicon more common in the military to denote granular instructions to achieve a task, it follows that the widespread usage of the terminology in COVID-19 response represents a normalization of the pandemic as war. Again, of course, this is something that was not unique to Uganda or to the African continent, but across the world, many governments and leaders did define and coach COVID response in terms of war and therefore military operation. So in the case of Uganda, the response really was built around a dual understanding of what the problem was. The problem was seen, one, as a medical problem, but not just medical, not just a public health emergency, but also a political problem. Medical, of course, obviously in terms of, enforcing, preventive measures, testing and tracing, so on and so forth, as well as surveillance and treatment, but also political in terms of COVID being potentially an external shock, an exogenous shock that could imperil Museveni's hold on to power, that could doom his regime, particularly given that his legitimacy has been on the wane and his hold on to power has increasingly become tenuous. And also considering that 2020 was a campaign year ahead of the general elections that were to take place and indeed took place early this year. So, in that regard, this was not just a public health issue, it was also a matter that needed to be managed politically. And so in both instances, both as a medical but also political matter, the military had to be placed center and to play central roles for at least two core reasons. One, the Ugandan military as an institution does have the kind of capabilities that other government institutions do not have. Now, this is, of course, understandable because, Museveni's state building since 1986 has been based around the military. So the UPDF, the Uganda People's Defense Forces, which is the national army, has been sort of the central pillar in regime politics and in state building. So for that matter, if you look at, for example, the annual national budgetary allocations, the defense and security sector tends to be up there in terms of taking the lion's share of the national budget. But secondly, Museveni at a personal level has enormous faith in the military as the most important instrument of rule. And of course, this is born out of his long-standing history as a specialist in violence, as a violent entrepreneur. So there are about 4 key areas in the COVID response activities that I'm focusing on in this paper, and which I'll expand on when I finish writing the draft of the paper. And I'm going to just quickly run through the 4 and to underline the role that the military was playing. The first one is in law enforcement. So once the national lockdown was announced at the end of March 2020, enforcing a national lockdown in a densely populated country like Uganda, whose law enforcement capabilities are quite limited under normal circumstances, meant that this was going to be a huge logistical operation that the police force alone would not be able to undertake. And so here, whether it meant ensuring that people don't violate the lockdown, by going out, shopping and, adhering to curfew hours that initially began at 5 p.m. up to 6 a.m. in the morning, later on extended to 9 p.m. to 6 a.m. All those law enforcement activities had a big hand of the military. Again, not very surprising, since policing in Uganda in recent years has become highly militarized, with a local defense unit, paramilitary personnel who work with the police, even though they are sort of supposed to be military guys. And then the second area was in monitoring and surveillance, and this became especially important because of long distance truck drivers and truck individuals coming from the coast, from Tanzania and Kenya, and particularly at the point where Kenya was, having surging numbers, and the Ugandan public health officials realized that after a long period of not getting any positive cases from the tests they were making, they started getting positive cases that were largely from truck drivers. And so the question became, how do you manage this problem, particularly because Uganda is a transit point for all sorts of countries that are neighboring Uganda: South Sudan, Eastern Congo, Burundi, Rwanda. All those countries have their shipment, materials and stuff coming from the coast going through Uganda. So here again, it was the military that was tasked with, escorting truck drivers from the border after they have been tested and their results are not yet known. They had to be escorted through the country to ensure that they don't, mix with local people. Now, this, of course, worked up to a certain point, but subsequently, it became almost inevitable that the enforcement mechanisms were not going to be able to deal with the problem satisfactorily. And then the third aspect is on, actual medical operations, treatment, managing cases, positive cases, particularly those that involved people who were severely sick. The UPDF, the National Army, has its own medical department, and it came in handy in partnering with the Ministry of Health, providing field medical teams, but also turning its medical hospital at Bombo into a COVID hospital for emergencies and intensive care management. In interviews I held with individuals in the Ministry of Health, they confirmed to me that doctors from the military were very much actively involved in a lot of the medical operations that the Ministry of Health was undertaking in its response. And then lastly, very important was the issue of food relief supplies that had to be, worked on after the government announced the lockdown. Now in a country like Uganda, where people really, exist and subsist by, going out to the fields and living pretty much hand to mouth, the lockdown was a big problem. And, before time, if the government was not going to be able to provide some kind of relief to people, it would have created a big problem for the government. And so through, something called Operational Wealth Creation, which is a program within the military, the government was able to mobilize corn and beans that were distributed to people, especially in and around Kampala. And this was again complicated logistical matter, and the government had to fall on the military to be able to do that. So those are sort of the four major areas that I'm focusing on, and we'll be doing more work on them to see. In all of this, of course, one of the more publicized aspect is the extent of human rights violations that took place at the behest of armed personnel, which again comes from the militarization of law enforcement, because military people, for the most part, are not trained to be law enforcement actors. Rather, they are trained to fight in war. And so COVID being framed as war meant that certain warlike developments and warlike actions in fact took place, and that entailed not just physical assaults on people, but also deaths as a result of the military participating in law enforcement. So just I guess in a minute or two that I may still be having left on the clock, Madam Chairperson, just some quick concluding notes. The pandemic did underline and put in the spotlight an important aspect of Uganda's civil-military relations, which is that the military still maintains central role, very much drives Ugandan politics, but also Ugandan social relations. From managing relief supplies and medical activities, we saw that the UPDF was in many ways the lead actor, in fact, in some respects, more important than the Ministry of Health. And of course, this is not again unique to the pandemic time issue. It's also it reminds us about the oversized role that the Ugandan military plays in politics in the country, which in part comes out of the history of the current military having been a guerrilla rebel group that worked among the people and fused social and political activities, and something that has been very much part of Uganda's political development since 1986. I believe I'm out of time, so I'm going to pause there, and thank you very much for your kind audience.
Great, thank you so much, Moses. Thank you to all of our presenters. These were very interesting across the board, and I actually, in a number of cases, I think they speak really well to one another. I've certainly noticed a number of common themes throughout, but given that we have about 15-20 minutes remaining, I certainly don't want to waste anyone's time by speaking. Let's see, I'm just going to bring us all back together. Here we are. What I'm going to do is just go in chronological order, depending on who asked a question in the chat function for now. So Dr. Simiyu, I see that you actually have posted a couple of questions. Perhaps you want to pick one to start with to get our Q&A session off and running.
I was just posting them in the chat. I thought you were going to read from there. So the first one was for Danielle about the situation in Kenya. My question was if there are the low cases in Kenya and Uganda in terms of infection, hospitalization, and deaths. Does that vindicate the strong measures that were executed by the respective governments in countering COVID-19?
Yeah, thank you for that question. I think I don't like to pass judgment in answering a question like vindicate the precautionary measures, but I would definitely say that there's a correlation between the two. So I'm trying to, even though I do have personal feelings on the subject, I try to remain neutral in assessing whether or not religious communities should be restricted in these ways during the global pandemic. But I think that, so when governments have implemented strong restrictions on religious communities, they've also almost universally done other things that we see in these cases as well, which is the kind of forcible quarantine is not quite the phrase that I'm looking for, but they've placed the people who've been violating these public health orders into quarantine and then done extensive contact tracing. And so by contrast, if we look at like the US, for example, or Brazil, which has not really prosecuted anybody, or there have been a couple of prosecutions, but they've been very minimal and restricted to the religious leaders for violating regulations about religious gatherings. There has been no contact tracing in those cases, no forcible quarantine, even when we know that perhaps several members of a certain church who attended a particular meeting not only contracted COVID, but in some cases died from it very early in the pandemic. There was still no effort to identify who had attended those meetings and to make sure that they were isolating or anything like that. So I think that there's definitely a correlation between the two things. Typically, we see governments who are taking these kind of heavy-handed measures against religious communities also doing other extensive measures to try to track and identify and quarantine the people who may be engaging in various kinds of high-risk activities. And this obviously correlates to lower rates of infection and death. So if that outcome is considered to be one that justifies these restrictions on personal freedom, which is kind of the broader legal question that countries throughout the world have been grappling with, and then yeah, it absolutely does vindicate them. But people definitely dispute whether or not it's justified.
Very good. And for Dr. Hisa, in addition to COVID-19, Uganda also held an election. And so how are the resources balanced, given that the military plays a very active role in not only countering the COVID-19, but also in managing the electoral process?
Yep, that's a great point, Dr. Simiyu. So, as the election, dates drew closer towards the end of last year, the general perception by critics was that government and Mr. Museveni were using the virus fight as a political tool to siphon resources, budgetary resources, but also to instrumentalize the law enforcement activities and the military's role towards Museveni's electoral goals. And that in many ways was the case. So you see the way the SOPs were being implemented, were being enforced, tended to be very selective, with opposition candidates being targeted for, violating SOPs while the incumbent could, get away with it, which is, the problem with having an incumbent, especially one who has been around for such a long time. He personalizes state institutions such that he himself tends to be above the law. And that was definitely a problem. So, not just, financial resources being diverted, but also law enforcement activities being tilted in his favor. I think I had seen a question by Dr. Wilburn, Ken Wilburn, about, so yeah, I think your question about the US, comparisons with the US with regards to the role of the military, I think that's an important point. I'm not too sure that I can write that much about the US and draw comparisons, but I think, as you know,
just begun. Yeah,
as you know, the Trump administration was criticized for not evoking the Defense Production Act, and
an opportunity to look at the statistics, because whatever the means was, whether the Ugandan military went too far, but it gives you the opportunity to promote Uganda in a way. At least it does for me, superficially looking at it.
Sure, and I think, I agree, and I get the point you're making, which is that, I think on the balance of things, the Ugandan military's role did make a difference. We don't know fully, how the balance sheet would look like, but the role of the UPDF did make a difference. And when you look at what happened in the US, of course, for the US, there's a big ideological issue there. I'm sure the Trump administration deliberately wanted the private capitalism to, be doing the work rather than have the government take over, activities that were supposed to, counter the virus. But yeah, I think, there's an important comparison to make there between what the Trump administration was not able to do and what the Ugandan government did in a very swift way, summoning the resources of the military to help in a fight that was defined as a security problem.
Great, thank you. Just in interest of time, I'm going to make sure everyone gets a bit to chat a bit more about their own presentations. Dr. Magu, did you have a question for Seth?
Yes, I did. So this was more of and I think I almost will guess the answer to the question is no, but Seth, I found actually all these presentations very fascinating, undercutting in my own research, because I'm promoting this whole idea of African regional economic communities, but countries are doing things differently. But so my question was, thinking about Madagascar and that concoction that it was promoting, and I think in one of your slides there was a Tanzanian state plane picking up supplies. Are there any other countries that have have accepted this, whatever it is? Because I think it speaks to two different approaches to COVID-19. Tanzania was deny. Madagascar was, it's there, but we have a cure. And I also thought to ask if you have taken any look at the African CDC and whether they have any opinion on these herbal cures.
Yeah, thanks. That's a great set of questions. So many African nations have accepted CVO, the DRC, Equatorial Guinea, Niger, Guinea-Bissau, goes on and on. Chad initially was one of the first nations to ask for some, if I believe, and I should say it's often framed as a gift. That's the way it's framed by the president. Subsequently, like some nations, so in Chad, after 34 people were supposedly cured after being hospitalized because of CVO, they got additional shipments. It's unclear if whether these were gifts or paid for. The argument is that money that's made from CVO doesn't go to the government, but it goes to this to IMHA, this Malagasy institute that is nevertheless somehow connected to the government, and that it's selling these products in public hospitals in Madagascar. And the second part of your question, the Africa CDC, I'm not so much familiar with that. I know that they've put together a set of protocols for how to move forward with clinical trials of African herbal remedies, I believe. But I think part of what I find interesting about this is that maybe I'm reading into this incorrectly, but I think a lot of this comes from the place that Madagascar, its positionality within Africa, right? This idea of a kind of lost Eden. Its plants are there's so many different endemic plants and animals, right? If there's a concoction somewhere, it might be in Madagascar. An argument that's very colonial. There's a way in which the kind of narrative of exceptionalism that Raju Elna is pursuing in this is both ironic because the main ingredient's from China, but also, kind of filters in some colonial logic in many ways.
Thank you. Dr. Paul, do you have a question for Dr. Boaz?
Sure, thank you. So Dr. Boaz, I was curious about whether or not the political standing of these religious groups matters in the cases you've looked at in terms of how they're enforced or persecuted.
Absolutely, it matters. Very, very significantly. And what I found, and I forgot I said I was going to post the link to my article in the chat. So what I discussed in the article that I already published, looking at South Korea, India, the US, and Brazil, is that minority religions are being targeted using coronavirus restrictions, whereas for the most part, majority religions seem to be given a certain amount of leeway, a certain amount of freedom. This isn't strictly across the board true, but it seems to be a general trend. And then I have to say that there's also a trend globally for Protestant Christians to be kind of some of the most vocal groups about protesting coronavirus restrictions, saying that their religious freedom kind of supersedes public health regulations. And so we find them at the center of the majority of a lot of controversies because of their vocal protests of it. So there are a lot of factors, but there's definitely a sense of persecution of certain minority religious groups. So it absolutely matters. And I'll put that article in the chat for anybody who's interested.
Great, thank you. Dr. Obidua, do you have a question for Seth, it looks like? Oh, I'm not sure we can hear you. I feel like we were having issues with your audio before. No, do you want to type your question in the chat? Okay, great. So while she is doing that, I'll give her just a second here to gather her thoughts. I have a quick question for Dr. Paul. So I'm interested, so I actually did some research myself in Liberia during the Ebola outbreak, and specifically from the perspective of what community members were doing in the absence of the international response, particularly at the beginning of the epidemic. And an issue that I found that was sort of problematic is individuals' sort of sense of distrust with the Liberian government for a number of reasons. One, because of, you know, their political history, right? But two, based on the fact that the Liberian Ministry of Health and the government really didn't have a strong track record of providing effective public health care to its population, right? And so I'm wondering how these civil servants, and I mean, I think there's going to be a difference, I would imagine, between, depending at what level they are, right? Community health worker, perhaps different position than someone higher up, but how they dealt with these issues of trust, or whether that came up in your research.
Yeah, thanks so much, Kristen. Absolutely, great question and topic. And you know, in many ways, I think that the Ebola epidemic caused a revaluing of trust and a reassessment of trust, and particularly that was clear when I talked to the Ministry of Health workers in particular, but also the Civil Service Agency more generally, and how they had to basically, in order to respond, once they finally got a coordinated response in place, but which was still ahead of the international actors, had to do that by building up trust at the local level. And I think in a lot of ways, that was a new negotiation of relationships that came about because of the crisis for Ebola. But I also think I didn't get a chance to mention it during the presentation. I think another really interesting element that that's at play is this trust with international organizations, and that was shaken during Ebola, and I think sort of comes to this day. And so Liberia has been allocated approximately 100,000 vaccines through COVAX, but they're AstraZeneca. And so all the Liberian press this week is focused on the fact that AstraZeneca is getting pulled off European distribution because of these blood clots or some emergency medical thing. And so the question again comes, and I think this has come up by other speakers today too, about what Dr. Sunga mentioned, but what trust can be put in these international institutions. And so I think these layers of trust definitely overlap, and when there's not, and I have some text in the paper about this, that when there's not capacity, it makes sense that trust is lost. And so conversely, the elements of building capacity, including at the local level, are what allow that formation of trust in systems that are reliable.
Great, thank you. Let's see. So I think we're just about out of time. So let's have Dr. Obido, if you don't mind being our final questioner of the panel, that would be excellent.
Yeah, can you hear me now?
Yes, we can.
Okay. Well, first of all, thank you, Seth, so much for your presentation and for actually putting that history down. I'm imagining that you plan to publish the work, right?
This is just totally unrelated to what I normally research, but it popped up, right? And it's popped up in international media. So
yeah. Okay. Well, my question has to just do with finding out a little bit more on where exactly you stand on the situation and how your paper is going to end. I like the fact that you clearly identify that it is complicated, and the whole issue of the Pan-Africanism with the history and so on. But I have to point out that German and Swiss chocolate, what makes them German chocolate? The chocolate, the cocoa comes from Ghana, from Africa, and yet it is Ghana, it's called German chocolate or Swiss chocolate. So just because the ingredient, 60% of it is from China, does not necessarily mean that it's still not an invention of the Malagasy. Number two is that, again, anytime there is an innovation in Africa, there is always this rhetoric that poses it as abnormal, as problematic. There is no African country that doesn't have garbage, especially through the colonial experience. You're always going to have a government that's questionable and issues that are unequal. So when do we cut the narrative? When do we start telling the other side of the story? When do we start reframing what's happening in a way that's new and different to move Africa to the next level?
Well, I think one thing, thank you so much for, there's a lot to think through all of this, and who knows if it ever will get published. But I think one thing I didn't have time to talk about is there are many Malagasy voices who are very critical of CVO, right? So I really highlighted those who were behind Rajoelina's move, and I think most are, but it's political right from the get-go, right? The way it's even labeled, the label is orange, which is the same color as his political party. So, I mean, on the one hand, I'm very excited because there's something here that is instructive or is to the West in a sense. And I try to talk about that a bit in the paper, but I also think maybe this is just my position as someone who's always skeptical. And there are many Malagasy who are also skeptical. So I tried to nuance the argument and show a variety of perspectives, but there's a lot of work to be done. So thank you so much.
Thank you.
All right, thank you all. I know I said that was going to be the last question, but I am afraid I didn't see the raise hand function when Dr.
Yeah.
was trying to ask his question. So
Yes.
we'll let you have the final question, and then we'll close up. Thank you.
Thank you very much. And I again congratulate everyone on this panel, including the moderator. I just wanted to say that the uses of blanket terms like concoction in reference to African medicinal efforts does carry a negative connotation, which unfortunately doesn't help our efforts to decolonize the discourse around African medicine. And I think we need to take that into account, right? To sort of acknowledge that there is actually a history behind the Artemisia COVID organics, which predates the COVID-19 itself. For some of you, I mean, most of you here are medical anthropologists, and you may be familiar with the name Jerome Munyangi, the Congolese, who had gone through a lot, you know, just as he was working, you know, on Artemisia to cure malaria. So I think he waged a fight against Western pharmaceutical companies. So that is in the background, and I think we need to bring that into the discussion as we deal with COVID-19 and the use of COVID organics, and also the nationalist thrust behind it. So I was going to ask the question to I don't want to mispronounce the name. I just wanted to throw in a question to look into, to ask if anyone who worked on the COVID organics did also take that history before COVID-19 into account. Thank you.
Sure, yes, I can briefly respond to that. So I use the word concoction specifically because I said that New York Post called this a concoction. So the only reason I used it was to show precisely that it was negative. So yes, I absolutely agree with what you just said. In terms of the long history, yes, that's all there. Couldn't fit that in the paper. Actually, the way that it came out in the Malagasy press, they did this full documentary that described how, and it's true that Artemisia was partly through, was tested during the Vietnam War, right? So there's this kind of anti-colonial history, this reading of it from Ratsi Mamanga, who was actually very close to other Vietnamese who were studying in France during the colonial period. So there's also a connection there in terms of Madagascar as seeing Artemisia as a kind of anti-colonial, the anti-colonial potential of Artemisia, right? So I agree there's a longer history to all this in Africa, but I'm much more, as an anthropologist, I'm very specifically interested in the Malagasy context because that alone allows so much that I don't have time to unpack here or even in an article, frankly. But yeah, thanks for your thoughts.